Dr. Compton Benjamin is a urologist and an assistant professor at the George Washington School of Medicine and Health Sciences. He is also the director of Urologic Oncology at George Washington University Hospital. Dr. Benjamin's clinical interests include prostate cancer screening and treatment, cancers of the bladder and kidneys, and disparities in minority access to medical care for diagnosis and treatment of urological diseases. Dr. Benjamin.
Good morning, everyone. Thank you, Ms. Farrington, and thank you to PHEN for inviting me to speak about a topic which is near and dear to me. Please, next slide, please. I'm going to warn you that I'm going to be using a lot of pictures, graphs, and numbers, so those who haven't had their coffee yet, please do so. I'll be talking a little about the natural history of prostate cancer and the importance of prostate cancer screening, especially with respect to African Americans. I'm going to tailor my conversation to African Americans because I think that that's the important subpopulation of the entire group of men who are at risk for prostate cancer. Next slide, please. So, prostate cancer, the most commonly diagnosed cancer in African American men. African Americans have the highest rate of prostate cancer, we have the highest death rate from prostate cancer, and we have, therefore, the highest rate of disparity. Next slide, please. Again, we've seen it previously, and African Americans have the highest incidence rate for prostate cancer and the highest mortality rates. It's about almost twice the rate of any other populations. Asians have the lowest rate, and the whites, which are higher than Asians, are still significantly lower than African Americans. There's a lot of research ongoing about what is the difference in African Americans that increases their risk. What we have seen, especially published recently, is that West Africans have some of the highest rates of prostate cancer. West Indians have some of the highest rates of prostate cancer. What's the common denominator? They are all descendants of West Africans. And so being of African descent seems to be the risk factor which increases your risk for prostate cancer significantly. Next slide, please. Again, this is just the incidence rates of prostate cancer. You can see that in the high 80s, 1980s, low 90s, there was a big blip. And that is because we started to screen for prostate cancer. And so we found it at a higher rate, but you can see that the rate of prostate cancer in African Americans, which is the green line, is significantly higher than the general population and for whites. Next slide, please. Again, the lifetime probability of getting prostate cancer for the general population is about 1 in 6. For African Americans, it's about 1 in 4. Next slide, please. And also the lifetime probability of dying of prostate cancer is 1 in 22, which is the highest rate. Next slide, please. Again, next slide. This is just to letting you know that prostate cancer is one of the highest rates. This is, again, death rates. The red line, again, being African Americans, and you can see there is no line that is near that line. It is head and shoulders above any other mortality rate. Next slide, please. DC, in terms of the prostate cancer death rates, number 2 in the country. Next slide, please. And what is that factor that has DC have the highest death rate and the highest incident rate? It's the population, the demographics of the population. We have a high number of African Americans in the DC area. Again, some more numbers. Are we still awake? Prostate cancer, second leading cause of cancer-related deaths. 1 in 5 African Americans, actually close to the 1 in 4, will be diagnosed with prostate cancer. 30% of cancers in blacks are prostate cancer. About 35,000 will be diagnosed with prostate cancer, estimated. Next slide, please. What is the screening test for prostate cancer? I mean, we previously heard that it is PSA. PSA is a 35 kilodalton protein. It liquefies semen. It is only produced by the prostate. So, if it is produced by the prostate, anything that allows that to get into the blood at a higher level will increase your index of concern that there is something going on in the prostate. The PSA test is not a prostate cancer test. It is a prostate health test. Whenever we see the PSA increase, we know that there is something going on in the prostate. For instance, having an enlarged prostate, having some kind of trauma to the prostate, having some instrumentation to the prostate, having prostate cancer, or an infection in the prostate. You can see that there are so many other things that can contribute to an elevated PSA, and when you have this discussion with your patient, you should let them know that, because one of the things that the USPSTF used to recommend against this is the anxiety associated with having an elevated PSA. Obviously, if I tell you, there are several things that this can be. I don't know what it is, but we'll take this walk together. You can diffuse the situation and relieve the anxiety. Next slide, please. So, the natural history of prostate cancer. This was a study that was done where patients who had confined prostate cancer were followed and were not treated. They were followed up to 32 years. Next slide, please. What you can see is that when these patients were followed, it took somewhere between 17 and 22 years before you can see a significant drop-off in patient survival. What does that mean? It means that prostate cancer is a very slow-growing disease. It takes a long while before the prostate cancer, in general, changes and gets out of the prostate and then becomes a bad player. Next slide, please. However, if you break people with prostate cancer down between the different types, low grade, intermediate grade, high grade, you can see in the green there is a significant drop-off in survival in people who have high-grade disease. Now, who's at risk of having high-grade disease? African Americans. Next slide, please. So, the survival for prostate cancer in general, when you use all of the new prognostic tables, the Parton tables, is generally over 95%. So, most people who come into my office and are diagnosed with prostate cancer, and because of the PSA test, it's usually diagnosed early and confined to the prostate, have a very good chance of being alive 10 and 15 years from now, sometimes even without treatment. Next slide, please. And as a result of that, and as a result of the treatment, there have been improvements in terms of survival, and there are many treatments that have emerged, including androgen deprivation, advances in surgery using the robot to remove the prostate, and new forms of radiation. All of these have contributed, in addition to advances in chemotherapy, to increase the survival with prostate cancer. However, we need to start thinking about prevention of allowing the cancer to get out of the prostate in those people who have significant aggressive-looking disease. Next slide, please. The U.S. Preventative Services Task Force, USPSTF, recommended against screening for prostate cancer. And they use many reasons, and they use several studies. Some of the reasons are because of the anxiety, as I'd said before. Other reasons were because of the harms that can be done with the biopsies of the prostate. We do our biopsies through the rectum, and there's bacteria there, and sometimes you can introduce bacteria into the prostate, and that can cause you to get very sick. If prostate cancer is found and you choose to have it treated, there are potential harms if you have radiation, damage to nearby organs, like the rectum, like bowel, bladder, problems with erections. If you decide to have the prostate removed, the nerves which are responsible for erections go right around the prostate. And so when you take those nerves off, or if you're not able to take those nerves off, you can have problems with erections after the surgery. There are also technical problems that you can have, including injury to the rectum, bowel injury, vascular injury, nerve injury, which can result as a result of the surgery. This is not very common, but it is something that can occur. And if it does, then that can cause you to have problems. These are the reasons why they recommend against screening for prostate cancer. They also looked at 4 randomized studies which were designed to look at screening to see if they benefited in terms of survival from prostate cancer. Next slide, please. Next slide. Of all of the 4 studies, there were 2 which were really good. And of course, when I say really good, I mean nice numbers, and they came to some conclusions. The European study, the ERSPC, and the American study. The European study looked at over 150,000 patients and categorized them either the patients who were screened with PSAs and patients who were not. And then when it was necessary, they were given biopsies, and when appropriate, they were treated if prostate cancer was found. Next slide. They were studied and observed for 12 years. The first report, which was done and published in the New England Journal of Medicine, showed a 21% reduction in prostate cancer mortality in patients who were screened as opposed to those who were not. Next slide, please. If you corrected for non-attendance and PSA contamination, the results go up as high as 44%. So, and this is a statistically significant difference. Now you got to get your coffee. I see some people going with those big words. Next slide, please. So, we see that there is a difference in the European study where patients were screened or not screened. How does this apply to African Americans? In this study, there were so little African Americans in this study that they made no analysis for high-risk population or for African Americans. And they recently published an update which showed that these results continue to be durable, that the survival is increased in patients who are screened for prostate cancer. Deaths for prostate cancer are reduced in patients who are screened. Next slide, please. PLCO was a study in the United States which looked at prostate, lung, and colon cancer and ovarian cancer. And they looked at about 76,000 patients. Now, this is actually the study which had the largest percentage of minorities, 4%. Next slide, please. When adjusting, they found that there was no significant difference in this study for patients who were screened versus those who were not. Next slide, please. And they looked at it in 7 years and 10 years. Next slide. Now, what were one of the problems with this study? A significant problem with this study is contamination. Now, what does that mean? It meant that a lot of the patients who were being used in the control group were already screened for prostate cancer or continued to get screenings with PSAs. What does that mean? Let's put it into another disease set. For instance, if you were looking at smoking and its effect in terms of lung cancer, and half of the group that were in the non-smoking group smoked and didn't tell you, and the results showed that there was no difference, you would say, well, these guys were smoking. Well, how can you have a control group that is being screened and look at the outcomes and then say, well, the outcomes are different? Well, obviously the study was very flawed, but this is one of the major studies which the USPSTF used to say that prostate cancer screening should not be recommended. So 44% of men in each group had undergone more than one PSA before entry into the trial. You need to have people who are not screened, no PSAs and follow those people, and people who have not been screened and then follow them for a long period of time. That would be a pure study that gives you information that you can really take home. Next slide, please. With the 4% of African Americans, they actually did a subgroup analysis, and they found several things. Number one, African Americans had higher PSA levels. They had a higher risk of high disease, 13% versus 8.8% in the general population, and more aggressive disease when it was found. And African Americans were less likely to get follow-up. Their recommendations in this study was that better follow-up of blacks were recommended because they are at higher risk of prostate cancer and prostate cancer mortality. I bet you no one has heard of this study. You only hear about the study where they recommended against PSA screening. Next slide, please. So we have already information which says African Americans are at higher risk. African Americans have a higher rate of prostate cancer, have a higher death rate of prostate cancer. Now, how can we take all of this information and still say that African Americans don't need to be screened? Next slide, please. Next. What we recommend at GW is that African Americans be screened for prostate cancer beginning at age 40 with a PSA test and a digital rectal exam. Next slide, please. Even the president, who is African American, needs to be screened. We follow the guidelines with whites and recommend that between 55 and 69 that they should be screened. However, anyone with a high risk of prostate cancer, including African Americans and people with a family history, a brother or a parent with prostate cancer, should be screened at the age 40 because they're at higher risk of having prostate cancer. Next slide, please. Once cancer is found, there are several treatments that you can have, including just watching the disease, active surveillance. And that's emerging now as a higher proportion of patients being followed that way. And that is because we realize that prostate cancer is overtreated. What we want to do is to treat the people who really will benefit from having their prostate cancer treated and watch those people who do not. There are lots of studies that are looking now for genes, for proteins that may be used to determine the high-risk patients. And those have not completely panned out yet for something which we can concretely say, you're a bad player. But we do know that there are some patients who will have aggressive disease on their initial biopsies, and those patients are at high risk of dying of prostate cancer. Next slide, please. So in conclusion, prostate cancer occurs at a higher rate and is more aggressive when found in African American men. African American men die from prostate cancer at a higher rate. And most importantly, the USPSTF guidelines which recommend against prostate cancer should not apply to African American men because they do not apply to African American men. Next slide, please. Thank you very much.
Ladies and gentlemen, we do have a couple of minutes for any questions for either Dr. Carter or Dr. Benjamin.
Yeah.
We have one.
1 second.
Good morning. Excellent talks. You both pointed out the fact that we don't have data in black men. Since so much of what we do in the U.S. is now really being driven, hopefully, by evidence, How do we get that data? How do we get the kind of evidence that will tell us what benefit there is and what the challenges and issues are with screening Black men?
Thank you. That many of these studies have not gone long enough. I mean, this is a slow, indolent disease in a lot of men, and I think that we have to sort of stretch the studies out and sort of see what happens, 20 years out. I think another piece is that, with all of the information coming with the Genome Project, I'm willing to bet that at some point we're going to find some things that are going to tell us that. We don't have them yet, but folks are looking at that, and the hope is that at some point we do that. But by the same token, we have to not let the men who are at highest risk sort of slip through the cracks. And it's a tough situation, as a clinician trying to figure out who should be screened. I mean, none of us want to miss a patient who has cancer. If you're seeing a patient, I mean, I'd rather not make a diagnosis, even if it's an indolent cancer, and let that person know that, and then offer some guidance about treatment options or no treatment. But to sort of not make the diagnosis is very tough, and even for an indolent cancer like prostate cancer. I think the other piece is that, the studies that the task force used to make their recommendations, as Dr. Benjamin said, are Dr. Andreotti, who was the lead author of the PILCO study, said we ought to be screening these high-risk guys. I mean, he said it to this group and to me. And the Christine Berg, who was at the National Cancer Institute, was the senior author on that PILCO study, a study that's been used like a hammer by certain groups to say not screen, but she said we should be screening high-risk people. So you got somebody who has put together a study saying you ought to be screening, and then a group coming out and grabbing the author's study and making them say something that they didn't say. I mean, I think it's just important for us to sort of think about that.
We have one more question.
Yes, sir.
Sir, if you would, please identify yourself. Thank you.
Yes. Name is Kevin Smith. Currently in the military, actively still serving. I'm over 53 years of age. I had 3 biopsies done. So I'm here also. I've been invited by your moderator, Colonel Artie Shelton. And I'm very curious. I guess I can be one of your first candidates here to be part of that study. I done had 3 biopsies, and I did the screening as that was recommended, I guess, by over 40, with the PS, and I still maintain a very high PSA count. But I have none of the symptoms in regards to they're saying that, as far as when it comes to some of those symptoms that are in there in regards to urination or anything like that. I don't have any of those recognizable symptoms. So, but the count from the screening stays pretty high. So, I guess where does that lead me? And that's where I'm at right now in regards to myself.
So we see that, and that's actually been studied at the NCI where I did my fellowship, where we looked at patients who had an elevated PSA and a negative biopsy. Usually when you have a biopsy done, you're looking at specific parts of the prostate where about 75% of the prostate cancer is found. If you have a negative biopsy there, chances are on your rebiopsy, we're going to biopsy the same areas. How do we change that? Well, at the NIH and a few other institutions, they've started using multiphasic MRI, which is an MRI of the prostate, to look at how the tissue takes contrast and how fluid moves in the prostate to determine if there are any areas of concern. What they also do is they use that information to guide the transrectal ultrasound guided biopsy, and it's called the image guide fused biopsy of the prostate. What they do is if the MRI can find an area, and sometimes it's not in the general area where you are biopsying, you can then say, this area is suspicious. Let's do a biopsy, and biopsy that with pretty good accuracy. There are some people who have just an inflamed prostate, And the MRI can add more information in terms of saying, hey, there are no areas that are suspicious. You shouldn't be very concerned. Even if there is a cancer, we don't see anything significant here. So I think the MRI is emerging as a tool that will help people in terms of negative biopsies to determine, are there areas that are being missed? These are some of the new developments which is allowing us to not do unnecessary biopsies and put people at risk of getting the complications like infection, which are associated with having repeat biopsies. So I would recommend at least talking to your urologist about getting the prostate MRI to see if that adds any more information in terms of your elevated PSA.
We have to make this the last question again. If you would, please identify yourself, and Doctors Carter and Benjamin will be around for your additional questions you might have.
Hi. Yeah, so I sort of butted in line, so this gentleman's going to have the last question, if you don't mind. I just wanted to make 3 comments. I'm Dr. Dennis. I'll be speaking a little bit later. 3 comments to that question. First is you mentioned symptoms. I think everybody needs to know that prostate cancer generally presents without any symptoms at all, that most men who are diagnosed with an elevated PSA have no urinary problems, no sexual problems, no ejaculatory problems. They're symptom-free. So if you're waiting for symptoms, you're waiting for late-stage disease. Okay, that's number 1. Number 2, there are 2 tests available for men like you that are approved and marketed today. One is the PCA3 test, and I'll touch on that briefly. The other is called the Confirm MDX, that will take a look at your negative biopsy, look at the methylation pattern of the genes in that biopsy, and tell you whether there's a high likelihood that the cancer was simply missed. And the third thing I wanted to say is that this meeting last year, Dr. Schaefer from Hopkins presented his data on African American men. And as Dr. Benjamin said, we're sampling just the posterior aspect of the prostate when we're doing the routine screening biopsies. And there's good evidence now that the distribution of cancer in African American men may be different in the so-called anterior part of the prostate, which is just not routinely sampled. And MRI may help pick that up. Now, last question.
Michael Shaw, Oakland, California. 2 short questions. A leader in Northern California would say, for the cost of a pizza, we won't test black men. What really is the cost of this PSA and what this country won't support this mortality rate with? 2, Dr. Benjamin, what was the name of the study? Because my question was, why can't we do a study on just African American men?
That's a good question. And, you know, the problem is, number 1, getting a large enough group of African Americans to screen and following them for a very long period of time. It takes funds to do that. And it's something that needs to be done, I agree. We need to screen African Americans and find out exactly how different they are. We've actually at GW done some genomic studies which look at African Americans and whites, and we see that there is a different pattern in terms of the genes which are expressed in their prostate cancer, with African American having more of an inflammatory kind of profile and whites having more of a neoplastic or cancer type profile in terms of the genes. I mean, this data is just preliminary, but it shows that there is a big difference in terms of the cancer and how it's developing between African Americans and whites, and how different they are.
I just said one quick point about the point before, which is about the imaging, which is very, very important. There are groups now pushing for mammography for men, mammography, which is using high-grade MRI equipment to be able to screen prostates. And the NFL is getting on board with this, and some other folks are, but most of the MRIs that we're using now, they use a system called Tesla to sort of rate how how sensitive the machine is, and they're using these high-grade Tesla machines to pick up things that sometimes get missed. So, but that's very expensive technology, and it's sort of like, you know, are you going to MRI every woman for breast cancer when mammography is so much cheaper? The big issue is what's going to happen with men, and I think, you know, it sort of goes back to men's health issues and how, you know, we as a gender, you know, don't put a lot of stock in it, and therefore nobody cares a whole lot about it, and so not much gets done. So we don't march and have rallies and do all the things that women do for breast cancer and other things, and I think guys have to sort of rally and sort of say that we want, you know, some of this high technology and get it done. So I think that we have to sort of, you know, generate a male health consciousness that pushes for these kind of things, and we just haven't done that.
The PSA test costs around $20, and that is significantly lower than a mammogram. And it's a simple blood test. A mammogram has to be done. You get a fee for that. And then it also has to be analyzed by a radiologist. The USPSTF recommended against screening for breast cancer. I guarantee you that every woman in this room has ignored that recommendation. But men will do anything that they can to avoid the finger.
Yes. Well, gentlemen, I want to thank you both so very much. Such a very interesting session.